So I would like to welcome everyone to today's webinar, Telehealth Pearls, Pitfalls, and Strategies to Improve Patient Experience. I would like to start off with a disclaimer that the views and opinions and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. This webinar is being recorded and archived and will be available for viewing after the webinar. Please contact the webinar facilitator if you have any concerns or questions. In case you're not familiar with the Pacific Southwest Mental Health Technology Transfer Center, we are a part of a national network of technology transfer centers and serve SAMHSA's Region 9, which includes the U.S. Pacific Islands, Hawaii, Arizona, Nevada, and California. You'll notice on your screen each region has 3 different colored boxes. The blue boxes represent the Addiction Training and Technical Assistance Centers, the green boxes are the Prevention TTCs, and the orange boxes, which include our center, are the Mental Health TTCs. As many noted in the chat box, not everyone is from Region 9. However, we are delighted to have you with us and hope you will continue to access and share our resources. If you haven't yet connected with your specific region's TTCs and would like to do so, please feel free to reach out to us and we are happy to connect you to the other centers. There will also be a link in the follow-up reminder that will help you locate your specific center. Our Pacific Southwest MHTTC provides training, technical assistance, and resources to support the mental health and school mental health workforce in our region to adopt and implement evidence-based practices across the mental health continuum of care. Here's an overview of our services. We offer no-cost support to the mental health field through webinars, like this session we're on today, as well as through coaching, consultation, resources, and tools and virtual trainings, as all of our on-site events are on hold at this time. So it is with great pleasure that I introduce to you today's presenter, Dr. James Armontrout. He is a staff psychiatrist with the VA Palo Alto healthcare system and has worked in a variety of different sessions and locations, providing telehealth across many different populations. And I will invite Dr. Armontrout to introduce himself further. Thank you very much. Welcome, Dr. Armontrout.
Thank you. Hi, everyone. I'm James Armontrout. I'm a psychiatrist. As Eliana mentioned, I work full-time at the VA, Menlo Park, normally in the trauma recovery program, and I'm actually temporarily detailed to the inpatient unit, so I've gotten to try out a little bit of telehealth there as well. And you can see a little bit of my background in training. I did my training in Boston, training in forensic psychiatry in San Francisco, and I have been with the VA for about 3 years now. And I've had the opportunity to use telehealth in a number of different settings, which I'll be talking to you a little bit more about today. All right, so today's talk is obviously inspired by what we've all been thrown into with COVID. No one really expected this to come. For many of us, we might not have really used telehealth before this, but suddenly we're all immersed in the need to use telehealth and to kind of suddenly be thrown into it. So what I'm hoping to do today is to talk a little bit about the benefits and the cost of telehealth, ways that you can improve the user experience, and to talk about some legal and boundary issues that are particular to telehealth. And my hope is not to give a full, how to get started guide, but more to give some words of advice, some pearls, some things that I've found from working in different settings with telehealth. And my hope is that you walk away from this talk with one or two things that will concretely change your practice for the better. And if you do, that's great. That's what I'd really like to get out of this. And when we talk about telehealth, there are a number of different technologies. What my plan, my focus here is going to be synchronous video visits. So whether that's a video visit to another clinic, for example, consulting with a primary care office, or a video visit to home, which has obviously become a lot more common with COVID, that's going to be the main focus of what I'm talking about here. And I also want to start out by saying, for everyone who's listening to this and who has been thrown into suddenly doing telehealth, well done. I mean, don't take anything that comes in this presentation as a criticism, because I think everyone has had to figure out their way as they go. And people have really come through with using new technologies, even if they didn't have the background and the training in them, to try to get the care done that needed to happen. So, with that mentioned, let's talk a little bit about why telehealth is exciting. So, when I think back to my residency training, we were encouraged to get psychotherapy ourselves. So in my 4th year, I got psychotherapy, and that was for a few months. And I remember Wednesday afternoon was always therapy afternoon. I would have to plan out getting started. I would walk probably 25 minutes in the ice and cold out to a little office in Boston, wait in the waiting room for a little while, do a session of therapy, and then walk back all the way. And I didn't want to schedule a patient right when I would get back because I don't want to be sweaty and flustered and, So really, through that whole time, I was probably using, 2.5 hours of clinic time. And that's, when you think about it, in the perfect setup for doing that I was a trainee in a program that fully supported it, that there was no stigma, that I could just announce, here's where I'm off to, and everyone was fully supportive of making sure everything was covered. If you imagine the situation that many people are in, taking 2.5 hours off from work is pretty difficult. But, for instance, maybe taking an hour at your lunch break could be a lot easier. So the travel time and the flexibility from the patient end is a huge benefit for telehealth. And that's considering a situation like when I was in Boston, which is a particularly well-served area. If you think about places that are more rural, that are more remote, those benefits can become even greater. Like when I worked in the Navajo Nation, we might have people that traveled 4 hours to come and see us at the clinic. If they're coming for a 30-minute follow-up visit, they might spend 8 hours commuting round trip for that visit. How much savings could you get for them just by being able to do some of the follow-ups even by video? It's also an access issue for some people that might not present to traditional visits, but who would be interested in coming to video visits. And we'll talk a little bit more about that. And I also think telehealth is really exciting because we're finally hitting what they referred to in the literature as a critical mass of familiarity and comfort with video conferencing technology. So if you think about trying to do a telehealth clinic, let's say in the 90s, the technology just wasn't there. People were using dial-up internet. We didn't have a smartphone in everyone's hand. But these days, many people do have high-speed internet. Many people do have an iPad or a computer that has a high-quality camera, or even a smartphone. So we've reached a place where the technology and the infrastructure is in place, and clinical practice, in a way, just has to catch up with what's already commercially available. As far as telehealth, cost is also a major consideration. So obviously there are cost savings for the patient, but you can also imagine situations like, let's say that there's a healthcare system running rural emergency rooms, and maybe there are multiple rooms that need to be covered, and they need one consulting psychiatrist or psychologist, maybe providing overnight coverage. You could try to staff everyone, or if telehealth is a feasible option, you could have one person sitting and remotely covering every site. It's also exciting that we might be able to get some better adherence or follow-up rates. You all who've been practicing over the past months might have noticed that sometimes it's easier to get people on the telephone than getting them back in person. And that may depend on the type of patient that you're working with, but that's another advantage. It also gives you the flexibility if you had an in-person visit scheduled. If it's clinically appropriate to do so, you could always convert it to a telehealth visit. And physical safety. Obviously, COVID is the reason that many of us are doing telehealth right now, that you're going to reduce your risk of exposure to COVID greatly the more you engage in telehealth as opposed to in-person visits. But there are other physical safety advantages as well. So many of you have probably worked in emergency rooms, you've probably worked on inpatient units where you've dealt with particularly agitated patients, and you may have to deliver some sort of bad news, something they don't want to hear. So for example, you might be telling them they're going to need to come into the hospital when they don't want to, or you might be telling them that they're not going to get a certain, let's say, medication, a benzodiazepine, an opiate that they wanted to get, or they may be intoxicated and agitated. So we'll talk a little bit about ways that telehealth can come into those situations and potentially improve safety for the clinician. And when we talk about telehealth, one obvious concern is it effective? I'm not going to spend a lot of time on this because it isn't really the focus of the talk, but I've included references to a few review articles that talk about non-inferiority or effectiveness trials for telehealth. And the takeaway is telehealth is effective and typically in terms of clinical outcomes achieves a similar response compared to in-person meetings. So for instance, Hilty reviewed evidence for non-inferiority or efficacy for geriatric general adults, psychotic disorders, PTSD, including a veteran population, emergency settings like emergency rooms, CBT for panic, and child and adolescent psychiatry, including autism spectrum disorder, and found good evidence across those various conditions. Reinhardt looked at emergency departments specifically. Kaftarian was the designer of San Quentin's, or the CDCR, California Department for Corrections and Rehabilitation's telehealth program, which has done a remarkable job getting telehealth out to more remote prisons from some of the better staffed prisons in California. So for example, San Quentin, for any of you who are familiar with it, is located in Marin County, beautiful setting, just across the Golden Gate Bridge from San Francisco, just across the bridge from Oakland. It's an area that a lot of people want to live, so they have an easier time recruiting than some of the more distant sites. And through telehealth, they're able to make up a little bit of that gap. Gentry showing that telehealth is effective in geriatric populations, which is a concern for some people, whether folks who are older, who may be less familiar with technology, will be as able to engage in this kind of care. And Hassan reviewed refugee populations, showing that it was effective there, but that providers and patients did prefer face-to-face. So having said all that, the question would be, why hasn't everyone been doing this all along? Why hasn't everyone been doing, let's say, half of their visits telehealth even before COVID happened? And I think with all of you having done telehealth work over the past few months, you can probably answer that question for yourself. There are a lot of barriers that still exist when it comes to telehealth, including, in my experience, some of the biggest ones have been with quality. So the internet connection is often going to drop here and there, which can be pretty bothersome when you're carefully listening to someone, especially if you're doing something intensive like psychotherapy or initial assessment. And a lot of these video conferencing technologies also use smoothing algorithms. So for example, if there's a cutout in the internet stream, they might then have the person speak very rapidly right afterwards. And that can also impair your ability to get an accurate sense of, for example, their speech or how interruptible they are, getting a sense that maybe they're talking over you when they don't intend to do that. It's just the technology pushing that along. It's also a lot harder to get a full sense of expressions, inflections, nonverbals, including any of the nonverbals that are happening off the screen. I have found that the mental status exam is another tricky area. We'll talk a little bit about that, but if you want to do a physical exam, that's a challenge. For example, you have a patient who is having a panic attack. You'd like to take their pulse because they're reporting some palpitations and just make sure that they have a regular pulse, no suggestion of any arrhythmia. Obviously, that's going to be a challenge if you're using telehealth. Basic things like physical steps to offer comfort. So for example, you have a patient who starts crying and you want to offer them a box of tissues. Again, that goes away in telehealth. The lack of eye contact can also be bothersome for a lot of people. So when it comes to eye contact, typically you and the patient are going to be looking at the screen. You're going to be looking at the other person. But what registers as eye contact is looking at the camera. So I'm looking at the camera now, and that's where you actually get your eye contact, or that sensation of eye contact. So that's a bit bothersome to some people. I've also found that the pace of interactions in telehealth tends to slow up a little bit. And I think part of that is related to that sense of interruption, of timing, of trying to jump in, take turns. It's just more difficult on a video platform because you don't get quite the same cues. And when you think about group interactions, you've probably read in some of the popular media about this concept of Zoom fatigue, which is a pretty big factor, especially when you have this array view of 12 different people in a meeting. And instead of just focusing your attention on the one person with everyone else kind of in the periphery, you've got everyone put on the screen right in front of you. So you're simultaneously trying to watch the expressions, reactions of multiple different people. And it's something that we're not really accustomed to. So you can get pretty tired and burnt out after doing too much of this. The self view can also be a challenge for a lot of people. And so even as I'm presenting now, I have the self view popped up on my screen, and I find my eyes often going back and checking the self view. That's something that you can actually do with many video conferencing technologies. You can hide the self view so that you're having your attention less often carried over. I've also found personally that the engagement level tends to be a little bit different when it comes to telehealth. So when I'm in person, I'll often jot a few notes in a session, especially if it's an intake. But for the most part, my attention is fully on the person in the room with me. When I'm doing telehealth, I often find it too tempting to just go ahead and take some notes, especially if the pace of the interaction is a little bit slower, if we've dealt with some technical difficulties, and I need to keep on pace. And that's going to create a little bit of a different experience for you and the patient, taking notes versus not. I also personally find my attention can tend to drift when I'm doing telehealth in a way that it doesn't in in-person interactions. And doing things like taking notes actually helps a little bit with that. Cowan et al., 2017, also laid out a lot of concerns that clinicians have with telehealth. And I've talked about some of these, but these are the common ones: difficulty picking up on nuances of emotion, discomfort about staying in the frame as you go on with the meeting. So, for example, if you lean back or you move side to side, you may be moving out of the frame of view of the patient. The eye contact feels artificial. You can't do the physical gestures for comfort. And a lot of clinicians also have concerns about establishing rapport in therapy. And clinicians in some studies have rated the rapport established in video conferencing as lower than the rapport that's established in person. Now, interestingly, when you look at some of the research data, it seems like clinicians seem to view the rapport as being more impaired by the telehealth medium than do patients. Patients tend to feel like rapport is more effectively established. So something interesting, in part that might be because a lot of the benefits of telehealth really go to the patient. You know, if you think about eliminating the travel time, making it more convenient, a lot of that's really going in favor of the patient, and often they really appreciate that you're willing to do telehealth. A lot of clinicians have also expressed concerns about the elderly, patients who are experiencing psychotic symptoms or in crisis, or patients with hearing or vision impairments or cognitive impairments. And there are also privacy and security concerns that we'll talk a little bit more about later. So, in terms of improving the experience, the picture I have here is just a snapshot from my work setup. And this is with a Logitech camera, 1080 resolution, and you can see pretty plain background. My office is pretty plain in general, and good framing, relatively good lighting. You know, this isn't like movie star quality or anything, but good enough for the purposes of telehealth. Now, these are going to be some examples of not so great ways to set up your telehealth angles. For example, I'll often see patients putting the phone onto a table or onto a desk, kind of propping it up, and you get this angle from down below. So in this picture, you're seeing an angle from down below, kind of a double chinning effect. You've got light up over my shoulder, casting a bright light on one side with very little illumination on the other. In this picture, you've got kind of a similar problem. If you have lighting behind you, you can get a halo effect so that you look kind of silhouetted. There's this blinding bright light that the camera may focus on, and you get washed out, which makes it harder for the patient to see your facial expressions and to engage. Here's another one with my laptop that has a particularly bad camera setup. So you'll notice for some people who are using their laptop, they start typing patient notes, and you get these giant squiggling fingers in the frame of the webcam, which can be hugely distracting. One of being out of frame with a room that's a little bit dark. And here's an example of one using a camera setup that's not very good, but framing in a decent way, having lighting that's okay, and having a pretty neutral background so that it still comes out an okay shot. Now this one I include because I've noticed on some meetings sometimes you'll see people who are sitting outside, looks like maybe they're sitting in the backyard, something like that. And you can have pretty good lighting, pretty good framing, everything. But I think the first thought that jumps to my mind, and the first thought that's going to jump to many people's mind, is who else can hear this? Because you're seeing the person is outside. Are there people walking by? Are there people who can overhear either what the person on that end is saying or what's coming out of the speakers? So you want to be mindful of how people are going to perceive that as well. So when it comes to the setup, basics would be a good internet connection. And one recommendation that Yellow Leaves and colleagues in a 2019 textbook has made is considering just a wired connection. So especially if you're doing telehealth from home, you may find that you have a better and more reliable connection by just plugging the internet directly in through the Ethernet port. So typically on your wireless router, there's going to be an Ethernet port. You plug that in, plug it into your computer, and then instead of using Wi-Fi, which may be more likely to go down, you're going to have that direct connection and slightly faster speeds. The webcam, so I would recommend getting a dedicated webcam if you're going to be doing much telehealth. And there are a few things to consider when you're looking for a webcam. You want to think about the angle the webcam has, the resolution, and how many frames per second you can stream video. So the angle is typically going to be somewhere between 68 and 90 degrees. And if you're doing one-on-one meetings, 68 degrees is probably plenty. If you want to include a full group, then you might want to think about widening that out to 90 so that you get more of a panoramic view of the room. Resolution, I would recommend going for at least 1080 resolution. And you can step that up to a high definition resolution. You could also do a 720 resolution, which is okay. But I think 1080 is, a pretty good middle of the road, reasonably high quality image. And as far as the frames per second rate, I would recommend going for a 60 frame per second rate. 30 is probably okay as well. You want to make sure that you get an appropriate microphone for your setup. So if you're buying a high quality webcam or a relatively high quality webcam, that's likely to have a good built-in microphone. Ideally one with noise canceling and multiple microphones is helpful just to make sure you're getting a good voice quality on your end. You also want sufficiently powered speakers or a headset, just to make sure that you can clearly hear the patient, because they may not have a professional setup, they may not have even a good setup. So you want to be able to turn that volume up and not miss what they're saying. And you want your setup to be stable. So sitting on a desk, using a tripod, something like that, but just not handheld. So you may see some people walking around holding a cell phone in their hand and doing the video visit, and that gets a little bit distracting because it's bouncing up and down, takes away some of the focus. You also want to make sure that you're using appropriate software, and we'll talk a little more about that. So this is my work setup at the VA. This is all just standard issue equipment, and this is about what I would recommend going for as the minimum. So you can see a 2-screen setup here. You can put the patient on one screen, and then you have the chart and other documents that you might need to review up on the other screen. Another option is just going with a monitor that's 27 inches or larger, and that'll typically allow you enough space to get the patient in and also to be able to pull up and access data. You want your phone available for an emergency backup in case the internet does go down. You can always use the phone to call them up. And the camera, again, you want to have positioned. Here I have it on top of the screen, somewhere about eye level. And in terms of framing, you typically want to have yourself with eyes about 2/3 of the way up the screen, taking up somewhere around half of the screen space, approximately the center of the frame. As we talked about before, lighting is key. So in terms of lighting, you typically want the light coming from in front of you and not from behind you, so you don't get that silhouetting effect. And you want relatively good lighting coverage. And during the daytime, that could be lifting up the blinds, getting some natural light in. If you have a room that's not set up well for good lighting, you can actually get a lighting ring, or some webcams have a built-in lighting ring that can provide a little bit more even illumination. And if you have to make a choice between video quality and audio quality would be the one to go with. So, thinking a little bit about web-side manner, which is a term that Galloway's again in the 2019 textbook talks a little bit about. You want to dress professionally. There's kind of the idea of working from home, working in your pajamas, and really you want to be dressed the same way you would in the office, including if you stand up quickly for one reason or another, you need to go somewhere, then you want to just look the same way that you would if the patient were coming in to see you in person. Dark colors tend to be a little bit more forgiving. And if you have patterns, you typically want those to be sort of smaller. And there are some specific training courses on exaggerating your nonverbals. So this is something that I haven't really done myself or looked into, but experts in telehealth, some of them recommend approaching it a little bit like you're a newscaster or a TV personality, where you're putting a little bit more emphasis on what you're saying, you're making your expressiveness more, because you're not going to get the same level of transmitting those responses as you would in person. So you have to exaggerate. Now, I think that could become a sort of tricky line when it comes to therapy. If you're doing exaggerated emotional responses, that it may throw things off a bit. But it's something at least worth considering, whether with your own personal style, you would want to, for example, maybe instead of a quiet you're making a more pronounced visual response so that the person sees that you're engaged and that you're hearing and following them. So in terms of regulatory changes with COVID, obviously there have been a lot. The American Medical Association has a good summary of changes that's updated pretty regularly. So for March 1st through the end of the national public health emergency, Medicare is paying physicians for telehealth services at the same rate as in-office visits. Medicare patients everywhere, not just in rural areas, can receive telehealth from home and other settings. Physicians can provide telehealth services from home instead of from the office. Controlled substances can be prescribed by telehealth. We'll talk a little bit more about that, but including buprenorphine or Suboxone, which has been really a huge benefit to a lot of patients who obviously need that continuity of care, but may not be able to make it safely into an in-person visit. And any two-way audio-visual device is acceptable for now. So FaceTime, Skype, Zoom, unless it's public-facing. So something like Facebook Live, Twitch, TikTok, you wouldn't want to use any services like that, for instance, on public media or where a patient's privacy could be compromised. So moving in to some of the legal and boundary considerations when it comes to telehealth. I think the one that is often on people's mind and that's probably most important to talk about is the standard of care. Could you end up getting sued using telehealth? And I think for a lot of people, when they think about the standard of care, they might think, well, there's going to be one for telehealth and one for in-person interactions. Because with telehealth, you're not getting quite the same level of quality of information. So maybe there would be a lower standard. But it turns out it's state by state, but typically that's not going to be the case. So for example, the California Board of Medicine says that telehealth is seen as a tool in medical practice, not a separate form of medicine. There are no legal prohibitions to using technology in the practice of medicine, as long as the practice is done by a licensed physician and complies with state and federal privacy laws. But the standard of care is going to be the same whether the patient is seen in person, through telehealth, or through other methods of electronically enabled healthcare. And so, in a practical sense, what does that mean? So the standard of care, which you're probably familiar with, it's the legal idea that you provided the care that a reasonably prudent practitioner of your discipline would provide. So, for example, under similar circumstances. So if you're a social worker and you're seeing a patient who's acutely suicidal or who has a particular health complaint, that you would do what the reasonable social worker would do under similar circumstances. And so what this means is you're going to be held to the same standard whether you were using telehealth or not. So for example, let's say I'm seeing someone who I prescribed an antipsychotic to, and they have kind of a bad internet connection. So I'm noticing some mouth movements for them, and I'm not really sure, are those mouth movements early tardive dyskinesia? Or is that just a glitch coming from the software where, say, it's speeding up some mouth movements because of lag? So that suddenly becomes very important for you to differentiate. Same thing, let's say that I'm prescribing a new medication and I need to get vital signs. I can't just say, well, we're doing this by telehealth, so I can't really get them. If you need to get it, if that's part of the standard of care, you would still have to find a way to do it. So there are a couple of solutions to that. One could be working with other members of the person's team. So if the person is in an outpatient setting, for example, working with their primary care doctor to try to coordinate doing a physical exam, getting vital signs. Another potential solution could be having a trained administrator who's on site, who is doing some of the telehealth visits. And I know the reaction that some people will get to that is, well, if you have someone who's there setting up the visit and, seeing the patient, then that person is going to run an exposure risk for COVID, which is true, but also a pretty different exposure risk. So if you think about what the exposure risk is, it's source control and time. So source control, things like wearing a mask, staying socially distanced, and then the amount of time that you're being exposed to the person. So if you had an on-site facilitator, they might, for example, greet the patient, stay 6 feet apart, walk them in, have them start at the computer, maybe briefly do any physical exam that needs to be done, and then they're out and they're on their way, as opposed to you might be sitting with the patient for 50 minutes, which is going to be obviously a longer duration of exposure and is going to carry higher risk. So that's another way around it. Another consideration would be thinking about a hybrid model. So for example, if you know that you need to get labs, do a physical exam, things like that, you could have the patient coming in for some visits and doing telehealth for other visits. But the bottom line is the standard is going to be the same ultimately. Licensing is another important point to consider. So the care takes place where the patient is. So that in an area like where I am in the Bay Area, that may not be too big of a barrier because you can drive for a couple hours in any direction and you're still in California. So if you're licensed in California, you're probably okay. But if you live near the state line, you'll actually need to think about where your patient is. And I would recommend checking in with them at the start of every visit to find out where they are, both in case of emergencies, which we'll get to a little bit later, and so that you make sure you're not running afoul of any licensing laws. Because technically, if they are in their home in Nevada, or if they went on vacation, but they knew it was a telehealth visit, so they went ahead and proceeded with it, if you're seeing them when they're in the other state, you may actually, or very likely are actually violating the state licensing laws. So just a key thing to know and to check in on, especially if you're anywhere near state borders and you have patients who may live in other states. And if they're coming to you, or even if they come to a site within your state, then that gets around the issue. Now, when it comes to the VA, there is actually a different standard. So there's a 2011 Service Members Telemedicine and eHealth Portability, or STEP Act, which allows VA providers to see people even doing telehealth to home, even if they're not licensed in the state where the patient is physically residing. So that's a pretty positive step forward. And I think I and a lot of other people hope that we continue to move in that direction of allowing for telehealth visits out of state. But right now, you just don't want to end up being the test case where that's becoming a licensing or board issue. It's also important to think about for asynchronous communication. So for example, if you're texting a patient, you're emailing them, things like that, those might be discoverable. So for any of you who've been deposed before, you probably remember the experience of getting your subpoena, which requests a whole boilerplate, multiple pages of information. And typically in that request, they're also going to request all relevant documents. So they consider texting to be documents, emails to be documents, a wide range of communication to be documents. So why does that matter? Well, that matters because if you're texting with the patient, you're emailing with the patient, a lot of sensitive information might get taken out of context. So normally, when you're doing your documentation in the chart, you're being thoughtful, you're putting things in context, you're having an opportunity to explain why you've made the choices that you've made. When you're doing asynchronous telehealth-based messaging, people can tend to get a little bit more carefree because they may not think of it as the same thing as entering a note into the patient's chart. And when that gets taken out of context, that could be twisted. For example, if there were to be a bad outcome, there were to be a lawsuit, then they could be honing in on that out of context. So the solution to this is, when you're messaging, keep in mind that it is discoverable and treat it like it's a part of the patient's medical record. And if you're working for a large healthcare system, you might have noticed that they already do this. So with secure messaging, it becomes a part of the patient's medical record. When the patient sends a secure message to their healthcare provider, the healthcare provider responds, it actually populates that into the patient's medical record. And just approaching all texting and all emailing in that same way is definitely the advisable way to go. So, psychological testing. Wanted to talk a little bit about this because in the forensic world, this is obviously a pretty big issue. Psychological testing can be really key in forensic cases and obviously in non-forensic cases, but there are questions about the validity and whether it might be challenged if you're doing it by telehealth. And so I know I'm giving this talk to an audience that probably includes a lot of psychologists who know a lot more about testing than I do. But this comes from my talking with one of my forensic psychology colleagues about some of the concerns that they would have administering testing by telehealth. So one of them, and this one is huge, is test security. Any of you who've signed up to administer tests, you probably remember signing an agreement that you're going to safeguard the intellectual property that's in the test. And the reason for that is pretty obvious. You know, let's say you're taking something like the test of memory malingering. If images of that test become widely circulated and people who are taking the test know what they're taking, then they might know how to respond in order to game their responses to present the way they want to present. And, you know, you would think that that's sort of extreme, but especially in forensic circles, it unfortunately does happen. Even tests as sophisticated as the psychopathy checklist, if you go online, you can find entire books that are dedicated to exactly how do you beat the psychopathy checklist. So for example, they'll say, well, this item, the reviewer who's evaluating you probably already has your record and they probably already know this. So you know what, for this, fess up to it and you'll win yourself some honesty points. For this item, here's how you should present yourself and here's how you should explain what you're trying to say. And so there's obviously a huge incentive in some cases to come across in a certain way with testing. And when the tests get out, that undermines the validity of the test entirely. In person, of course, it's possible. Someone could, for example, have a tiny camera and be recording the testing materials. But if you're doing a telehealth evaluation and no one is there monitoring on their end especially, then it becomes pretty much trivial to compromise those testing materials. For example, they could prop up their phone and just record the entire thing, get all of the questions, all of the images, and post that anywhere. So that's a big concern. But beyond that, you have to ask whether the testing is normed for the conditions that you're administering it. And unfortunately, often the answer is no. Often tests are normed for in-person administration. So you have to ask questions like, if there are technological problems and the person is frustrated Are they maybe going to pay a little bit less attention? Are they maybe going to perform differently on the testing than they otherwise would? Is the person going to have concerns about confidentiality? Is that going to change their responding pattern? Could the person have a third party in the room that might impact test responses, including by coaching? So for example, if you have your camera and you have your field of view, they could have someone sitting off screen giving them cues about how to respond to the psychological testing. And again, if you have no one on site or you don't have multiple cameras to try to, confirm that they're alone in the room, you could be completely oblivious to that. It might actually change the test you choose to administer if you're doing remote testing, which might also be a deviation from your normal approach to care. And as I talked about, there's sort of limited evidence base for psychological testing. So the bottom line is, for testing, doable, but with a lot of caveats. And one way that some psychology colleagues I've talked to are proceeding is having a proctor on site. So again, you've got someone who brings the person in, makes sure they're situated and comfortable, who's on site to handle things if they come up, but who's not sitting there and administering the test. And then the psychologist can administer the test remotely, monitor with the camera with a person on site, so that you're improving the test security and making sure that it's a more valid administration. So at least for the time being, that's one potential option to get around the testing concerns. In terms of controlled substances, I mentioned before that some of the requirements around this are suspended, including the Ryan Haidt Online Pharmacy Consumer Protection Act of 2008. So this is an act that was likely inspired by some of the less reputable practice you see out there. So some of you might have seen the Netflix documentary, The Pharmacist, talking about one of these, what they call pill mills, where you have a physician who's just writing huge volumes of controlled substances to a lot of, basically to anyone who comes along. And acts like this are meant to try to limit that. So the Ryan Haidt Act says that if you're prescribing a controlled substance to someone, you have to have seen them in person first. You can afterwards do a telehealth visit, but you have to have that initial visit with them. And while on the surface it can seem pretty reasonable, that could end up with some negative unintended consequences. For example, let's say you're seeing a child with ADHD who's been stable for years on their medication. They've been working with a colleague that you trust for years, and you're taking over care for them. They live hours away from your office. Well, they're still going to have to come in and see you before you can prescribe them their stimulants, even if you have no suspicion at all that they're abusing it and you feel very confident in the diagnosis. So sometimes that can be treatment interfering. But during COVID, that has been suspended, but obviously likely to come back at some point, and it may be something that gets revisited by the field. When it comes to malpractice insurance, you want to think through several different things. So first off, does it cover telehealth at all? And odds are good that it does, but you want to contact your malpractice insurer unless you have it in writing and clear, and just verify with them that it does. And the recommendation is that you would get that in writing, because you don't want a scenario where years down the road you actually have a bad outcome and you have used telehealth, and then you're relying on the report of someone that you spoke to years ago who's a representative. There's really no proof there. So basically, it's good to have them include that either at least in an email to you or just adding it to the documentation. So for example, I work through the VA, so obviously I'm not privately insured for the clinical work, but I do private forensic work. And when I do the forensic work, I have to have my own private insurance policy. And I spoke with them directly, and they include that forensic work is covered on the policy confirmation sheet itself. I think if you're going to do a lot of telehealth, it's worth doing something like that just for the peace of mind to know that you're covered. In addition to just being covered, you want to find out if any special rules apply. So for example, some insurers will ask that you have a first visit in person before you do ongoing telehealth. If that's the case, obviously you want to know it so that you can either renegotiate that, consider a different insurer, or make sure that you're in compliance with whatever their requirements are. In terms of emergencies, a few important things to know. I think the most important one is when you dial 911, for example, if you need a patient to be involuntarily transferred to the emergency room, or you need a welfare check, anything like that, that's going to reach your local police department. So this is where it pays to do a little bit of preparation in advance. When you're doing telepsych to an area, you want to look up the numbers for the local police department and have that readily available, because during an emergency is not the time you want to have to try to be gathering this information. When you're trying your best to monitor the patient, to talk them through it, you're also trying to look up and coordinate these things. That's not ideal. Now, if you're working for a large healthcare system, some of them, you want to check and see if they have, for example, an E911 service. So for the VA, they have an E911 service. You click that, it'll connect you with local first responders more directly. But if you don't have that, you just want to do that homework beforehand so you're not stuck doing it in the moment. Another consideration with emergencies, obviously, in real life, the patient could get up and try to leave the room or run out of the office, and sometimes that happens. But with a telehealth interaction, it's much easier. The patient can literally just hang up the phone, turn off the video. They can disappear. That's why it's important to do a little bit more homework again in setting up an emergency contact for local emergencies or issues. So, for example, the person might have a spouse, or they might have a friend that they're very close to, or someone who can be around and available to try to help out if you get that sort of dysregulation, so that you're not getting the person just walking off frame and then they're gone. And this brings up the question of, should you see patients who are likely to be unstable using telehealth? And I think this is a pretty valid question, and it has a lot to do with what the resources are that are going to be available to manage that emergency if it comes up. So for example, does this person have a lot of supportive family at home that would be there to help coordinate the response? Then that might weigh a little bit in favor of seeing the person by telehealth. But if there's someone that you view as pretty high risk and the resources available to them are pretty scant, that would personally make me a little hesitant to do telehealth. I would typically prefer to get them in person somewhere. And that might even be, for example, going to their primary care doctor's office, getting set up in an office and doing telehealth from their PCP's office, where you have on-site support and staffing. Could be something as simple as that, but just making sure that there's adequate support in place so you don't end up landing in that spot of having to deal with a situation where you suddenly find yourself over your head and beyond the resources that are available to you. Privileging and credentialing. Just going to briefly mention that reciprocity is something that is gaining momentum in recent years. And it's honestly not something I know much about, but if you are interested in getting credentialed at remote sites so that you can do telehealth to other healthcare systems, take a look into reciprocity and whether it could be an option for you, because that can streamline the process and make it a whole lot simpler. The Yellow Leaves textbook that I include in the references section has more detail about some specifics on that. You could also check in with your department. And in terms of insurance and Medicare reimbursement, so I am sort of fortunate in a way that I don't really deal with insurance. I work for the VA in my clinical care, and in forensic work, you can't bill insurance. So I don't have a lot of experience with working with insurers, but for those of you that do, you're probably seeing that a lot more of them are paying for telehealth visits right now because of the public health emergency. But you want to keep a very close eye on how long that continues, because for many of them, at least for now, it's temporary. Now, I think the hope that many of us have is that it's not going to be temporary long term, that maybe this is going to be the push we need to go ahead and get better reimbursement structure for telehealth. But for now, I just point this out because if you are billing insurance, I would strongly recommend knowing exactly when and if payments for telehealth are set to expire. And one last point as far as legal issues, I would recommend holding informed consent conversations around the limitations of telehealth. So you want to review any potential vulnerabilities, including unexpected or even unforeseen privacy breaches. So as one example, WhatsApp was acquired by Facebook and apparently inadvertently revealed patient lists for psychiatrists because many of these patients had their psychiatrist listed as a contact, and then it recommended, well, you should be friends with this person because you both have a mutual friend, Dr. Williamson. And obviously that becomes problematic. You also want to document that you had this informed consent conversation about the limits of telehealth. And I'm also realizing, as far as potential vulnerabilities, one important one that we haven't talked about is information security. You want to make sure that you're in compliance with HIPAA and that you're in compliance with the HITECH Act, that basically you are using a platform that's keeping your patient's information secure. One good way to do this is by finding a reputable provider. So someone like Microsoft, one of the electronic health records vendors, Google has a G Suites option, and then signing a business associates agreement with them. And this is really key, it's really important, because HIPAA, if you're going to be sharing protected health information with third parties, requires that you have a signed business associates agreement with them. So a lot of these major platforms have provided this as an option. You can contact them, let them know that they're going to be processing patient data, and then they implement the appropriate safeguards, and you have a signed BAA with them. But you don't want to just go ahead and use, for example, you sign up for a paid G Suites account and you're doing video conferencing and you're saving patient records to the Google Drive. Even though it's a paid account, if you don't have a business associates agreement in place, you don't have a setup that is meeting the requirements of HIPAA. And when it comes to information security for information that's stored about the patient, the recommendation that many experts make is actually to save that to an encrypted, password-protected external hard drive that you then lock in a file cabinet, much like you would paper records. So that's something you can look into, some of the pros and cons of cloud storage, and obviously many electronic health records do cloud storage. If you do that, you want to make very sure that you're following all the relevant privacy and confidentiality laws, or encrypting a drive, putting it in a locked space, makes it very difficult for that information to become compromised. Even if someone were to steal the drive, it would be very difficult to access. Now, I wanted to talk a little bit about boundary and clinical issues as well. So, on the one hand, it might be easy to think boundary issues are going to be much less of a problem because you're not seeing the person in person. You know, how is there going to be, for example, inappropriate touching if there can't even be touching? So that distance provides protection. And in some ways that's true, but it can also provide a false sense of security. So having that sort of distance can cause people to let their guards down a bit. And you have to be very careful, because not only are people potentially letting their guards down a bit, but you're using a medium that doesn't have the same traditional kind of ritual around it as coming to a therapist's office or coming to a medical doctor's office. So you're doing something that many people in their minds may associate with hanging out with friends, video chatting, things like that. So it becomes particularly important to make sure that you're keeping boundaries as far as the start time of the appointment, the style of interaction. You want to bring the same style of interaction online with a patient that you would have with them in person. And also looking at issues like social media. We talked about not using public-facing video platforms. What if someone invites you to be a friend on social media or to like or follow certain groups? And there, I would recommend, just like if you're seeing someone in person, that you're very careful to keep the professional and private interactions separate, that you avoid the boundary crossings that sometimes later lead to boundary violations. Because when you do these reviews of cases where boundary violations occur, they are often preceded by boundary crossings. And pretty important distinction here, boundary crossings, you're probably familiar with, are things that are out of your usual practice, but that are done in the interest of the patient, typically, that don't result in significant harm. So for example, maybe a patient is sobbing because they just lost a loved one, and the therapist gives them a hug. That might be a deviation from their normal practice, but that might be a boundary crossing rather than a boundary violation. Boundary violation is when you are doing something that's exploitative to the patient, or where you have basically crossed a line into inappropriate conduct. And what the research typically shows is it's usually not just an immediate leap to boundary violation. It's a slow accumulation of boundary crossings, ultimately leading to a boundary violation. And so I think that's why it's important as a profession, as a field, as mental health workers, as we start going into doing many more telehealth visits, that we make sure we're not allowing that slow creep to start to occur. Some research has shown that patients will project their feelings onto the physician more readily through telehealth. So that's something to be aware of. And in a way, it kind of makes sense when you think about the psychodynamic idea of the blank screen, that you have the therapist who is generating feelings from the patient that are transference, that the patient is projecting their own feelings onto the therapist. That's promoted by that neutral stance, by not showing strong reactions, by not making it necessarily as clear what you're thinking. And so if the video medium is doing that for you, if the video medium is taking away some of the reaction, then the patient may have a little bit more room to run in interpreting what you're thinking and what you're doing a little bit more based on projection rather than reality. And one survey of 48 state medical boards showed that the most common violations of online professionalism were inappropriate patient communication online, sexual misconduct, or prescribing without an established clinical relationship. So sort of similar to in-person interactions, but obviously with the twist of some of the prescribing more remotely. When we think about the physical environment, so on your side, when you're thinking about the interaction, think about it as an exam room. Your side of the camera is the exam room, and their side of the camera is also your exam room. And when the patient is looking through the camera, what do they see, and what does that say about you? So, key considerations there are, what is the patient going to see in the background? Right now, you probably notice I have just a very neutral background of a wall behind me. That's one option. Even better option is having a setup of some books, diplomas, office furniture, things like that. But if you're doing healthcare from home or telehealth from home, you have to be careful because it can be easy to accidentally show things that you might not have intended to show. So maybe you're showing pictures of your family that are on the wall. Maybe you're showing posters that talk about particular interests you have that you didn't intend to introduce into the clinical relationship. So before you start telehealth, especially from home, just survey the environment and take a look at what the patient is seeing and consider that as all part of the way that you're presenting yourself. In terms of their side, what can you see and what does that say about your patient? So again, thinking boundaries, you may see things that you wouldn't have seen if the patient came into your office. You may see their family members, you may see their kids running through the room, you may see their pets, or you may see, for example, offensive decorations or offensive objects in the home. That could impair the clinical relationship. So you probably want to talk with your patient beforehand. Even consider something like giving a standard packet. Here's a good way to set up the telehealth visit. This will help me see you as best as possible and will help you have the best care out of the interaction. You also want to think about the risks that can come up because you don't control the environment. And this is pretty huge, kind of analogous to the concerns that come up with psychological testing. If you're not controlling the physical environment, especially if you don't know who's around, there's a potential for an information breach on their side. And in some cases, that could be pretty important. So for example, think if you're working with a domestic violence victim and they're at home, their abuser could be listening. Those are issues to think about beforehand, to bring up with your patient beforehand. Is anyone else in the room? Can anyone overhear? Even considering things like they could get a white noise machine and place that outside of the room to provide some additional security. One other trick that I've had some colleagues tell me about using that you might want to consider for your own telehealth practice or for your patient if they needed to. If the house is chaotic, the kids are running around, or people can overhear everything you're saying, for some people, going to their garage, getting in the car, and doing the whole visit from the car has been effective because that's going to provide a lot more of a controlled environment. Obviously not optimal, not the first choice, but it at least improves that information security. You also have to think about whether your patient is going to try to multitask. So childcare, that's a huge one. Big convenience that you don't have to be gone as long, but people might try to start doing childcare while they're in the middle of a therapy session, or cooking, or eating, or smoking. All of that's going to become a boundary issue because, again, you want telehealth to be equivalent to in-person care. You wouldn't have the person, cooking their dinner in your office while you do therapy with them. And I would discourage having them do those kind of things while they're in session with you by telehealth. You want to really preserve that frame. If you're doing telehealth to a clinic, you have to think about who's the staff person that you're going to have on site. What kind of qualifications do they have? What's their training and experience? And how are they going to interact with the patient? Are they just walking them in and saying, here's the setup, is everything good? Great, give me a call if anything's wrong. Or are they there monitoring? How are you going to communicate with them? So, for example, when I was working for the prison system in California during forensic fellowship, we would have the on-site administrator and we would text back and forth with them throughout the visit so that they could immediately respond to any on-site issues. But they are stepping out, they're stepping away so that they're not hearing everything that's going on between the visit to preserve the patient privacy. So just things to think through if you do end up using an in-person proctor or assistant. We should also think a little bit about how to use distance. So we talked a little bit about decreasing physical risk. I know myself, I've been kicked at, I've had water chucked at me, I've had people tower over me and yell. One of them so intoxicated that then they turned around and walked face first into the office door. Obviously, telehealth can help. And part of that could be they may be very angry with you because maybe you're not prescribing them what they want. Maybe you're saying they need to go to the hospital. Maybe you're denying them admission to a program that they want. That may decrease some of the liability on your side. Now, obviously, if you have staff there, you have to consider their safety. So you have to think of them as your responsibility. And if you see things going in a direction that could become violent, then just like an in-person interaction, you want to have the appropriate infrastructure in place to deal with that. So whether that's security presence or stopping and resuming at a different time, you want to be able to manage it in that way. But at least it decreases a little bit some of the potential for impulsive acting out that you might get in an in-person interaction. Some authors have recommended or have described taking sort of the bad cop role. For example, if you're a consultant to an emergency room, you might be the one breaking the news to the patient, yes, you're going to have to go into the hospital, and maybe some of the on-site staff can preserve some of the working relationship. Well, I'm sorry, that's what Dr. Armontrout says, he's placed the hold, there's really nothing I can do. And so you're playing a little bit more of the bad cop role with that distance and helping some of the on-site people preserve some of the working relationship. For some people, there may actually be less embarrassment with sensitive disclosures. So it's easy to think of people who might feel hesitant to disclose because of the potential for a data breach. But some people actually feel differently and view it as a kind of confessional. You can use the distance to better assess family dynamics. They may be less responsive to you because you're not in the room. You may be able to get a better view, especially for parent-child interactions. And for anxious and agoraphobic patients, I think you have to think a little bit pros and cons. In a way, let's say an anxious patient, part of the treatment could be coming to my office, making it out of the home, coming to a place that I hope comes to be known as safe for them, but doing something that's out of their comfort zone. So in a way, doing telehealth to home could undermine that. But in another way, they might not be able to make that trip out yet. Maybe by doing telehealth to home, you're going to get them to the point that they could do that. So you have to weigh that out on an individual basis. In terms of physical exams, we talked a little bit about that. I would recommend generally either doing a hybrid model where you see them in person part of the time when you need to, or working with other professionals on their team so that they're getting all of that done. But the key is just making sure that you're doing all of that at the same interval you would if you were doing in-person visits. For paranoid patients, one recommendation I read that I've never tried is they may have trouble being directly in the frame of the video, but you might consider having them step aside out of the frame of the video until they feel more comfortable coming back in. And that has helped for some paranoid patients. In terms of stigma and distance, obviously in small towns, this can be a boon. So even training in Boston, I lived right next to the hospital and I might go out and see my patients right there, you know, wandering around outside of the hospital or in the community. And if you're from a small town, that can be an even bigger issue. So sometimes that can work in your favor. You're local, you know the resources, you know the general climate there, but sometimes that can have a negative impact. So that's another potential consideration when it comes to boundaries, that the remote person is going to lose some things, but also gain some things. Now, I'm not going to spend much time on mHealth because I want to have time for questions, but mHealth apps, I just want to point out a few very brief things. One is if the app is not connecting them to a provider in traditional telehealth, it may very well not be covered by HIPAA. So the privacy policy is going to be controlling. And I included this example in one of the papers I wrote on the topic because it tells you just how loose those privacy policies might be. So if you submit or post any materials or content to this site, you grant us and our affiliates a royalty-free, perpetual, irrevocable, transferable, assignable, sub-licensable, worldwide license to use such materials and content, including alterations thereof for our business purposes in any form, in any media and via any technology we choose, whether it exists now or is created in the future. And so when I read that, I take that to mean if they wanted to take your therapy session and turn it into a Super Bowl commercial using a holographic technology that doesn't yet exist, that seems like that would be okay by that privacy definition. So you just want to be sure that if you're recommending apps, you and the patient have read the privacy policy and that you feel okay with it. In terms of FDA oversight, relatively weak oversight in many cases. There's both the Me Too pathway and many apps that are general wellness apps are deemed low risk, get little or no scrutiny at all. And the FTC does do some policing of apps, but typically their portfolio is dealing with claims that are not backed up by the evidence. So the most famous one, Lumosity's $2 million settlement, they have gone after some other apps, but the takeaway is many apps haven't faced a lot of legal scrutiny, so you have to be able to read up on that and weigh the risks and benefits with your patient. And for this slide, I'll just mention for apps that incorporate coaches, when you review some of the outcomes for unlicensed coaches, lawsuits tend to be pretty rare. So you would have to look at what is the app claiming to do? Are they claiming to treat a disease or disorder? If so, then that's probably going to fall under a lot of relevant law. But if they're just claiming that they provide coaching or that they help with sad mood or something like that, that's probably going to be very unregulated. And again, if there's a bad outcome, it's likely that they would be going after the licensed healthcare professional, which would be you if you're recommending the app. And just a couple of examples of novel app-related lawsuits that came out when I reviewed some of these a year or two ago. One's about Fitbit's heart rate discrepancy claims. One lawsuit on FaceTime where a person was FaceTiming and rear-ended a car and killed a child, unfortunately. And the parents brought suit saying that Apple should have disabled FaceTime when a vehicle was in motion. Another warrant in Bentonville, Arkansas, to turn over data that might have been recorded by an Amazon Echo device. So just being mindful that there are some unknowns when it comes to apps and that there can be novel ways to find a lawsuit. And lawyers are very good at coming up with those novel mechanisms of action. So I'm going to open it up for questions.
Thank you, Dr. Armontrout. This was a phenomenal presentation. I really appreciate both the breadth and the depth with which you have approached telehealth pearls and pitfalls. I'd like to invite audience members to enter any questions that they might have into the questions box. And while people have an opportunity to write their questions in there, I have one question that I'd like to pose to you, Dr. Armontrout. I really appreciated the attention that you paid to support people who might be engaged if a crisis situation should arise in a telehealth context. And I wonder if you might talk about whether or not you communicate ahead of time with the support people, and if you do any releases of information, or how that engagement is negotiated between yourself and a telehealth context.
So that's a great question. And I would recommend, if you're counting on someone being the support person, if you anticipate they might be used, I think that it would be very wise to bring them in and to talk with them a little bit about what you might anticipate. Now, often, if I'm working with someone where I honestly believe they're pretty low risk and it's pretty unlikely, I may just talk to them and say, okay, who can you call if you're feeling dysregulated, if you need someone to talk to? Oh, you know, this friend, they're always there for me. That might be good enough. But yeah, I think if you're dealing with someone who's sicker or who's more likely to need hospitalization, I think it's good to, at some point, bring in that support person and have that conversation with them explicitly.
Thank you. I see a couple of people are typing a question in. While those questions are coming in, I wanted to point out that Raul Gomez shared a comment earlier about a recommendation of setting the web ICAM at eye level and looking at the web ICAM when it's the clinician's turn to speak. Raul states that it can help with the eye contact when it feels artificial. Dr. Armontrout, you had also mentioned the lag time in bandwidth and technology and how clinicians might over-exaggerate certain facial expressions or just be aware of the speech patterns. Is there any, or do you have any kind of words of wisdom to around making it feel more natural in terms of the way that you speak or that you express yourself?
So honestly, the way that I've done it, I usually interact on the video call just the same way that I would in person. I've found for me that that works pretty well, but I think my own style is pretty reserved and, I'm pretty calm, quiet in person as well. So I think that my patients are sort of used to that from me. I think for different people with different styles, it may work differently. But honestly, I typically don't do a lot different except just avoiding doing some of these very minor, like a small nod or a, just being more clear and verbalizing more often.
Terrific, thank you. I see we have a comment and question from Brittany. Brittany says, I work in crisis services and currently do telehealth crisis assessments. For instance, individuals in the ER or police stations. Who does the risk of confidentiality violation fall on, since in these situations there is no alternative location to speak with the individuals?
So that's a good question. I would think the setup would likely, so sort of a two-part. One, I think that a lot of the liability would fall on, for instance, the ER, if they're not taking appropriate steps to safeguard the patient information, but it would probably end up falling on you too. So I think in a situation like that, you would want to know if there are major data privacy concerns. I would address it with them directly and ask them to correct those, because ultimately I could see it affecting both them and you. And of course, in some settings, there's just going to be, there are going to be privacy breaches. Like in person, I'm sure many of you, myself included, you've worked in ERs where you go in and there's a small curtain separating you and the patient next to your patient. And obviously that person can hear everything you're saying. So in a situation like that, you just try to keep your voice low, minimize, the data breach as much as possible. And that's been pretty much accepted as common practice. But I think if there were more serious problems, I would want to take that up directly with them. And if they couldn't be remedied, personally, I would consider not working in that setting.
Terrific, thank you. We have a question from Jessica Selby who asks, is a verbal contract for safety in accordance to laws and ethics of the BBS?
And what's the BBS?
I'm assuming it's the Board of Behavioral Sciences.
Got it, okay. So, contracts for safety, I personally find it useful to ask a patient to contract for safety, because if they refuse to, that tells me I need to seriously think about a higher level of care. But contracts for safety, unfortunately, the evidence hasn't really shown them to be effective. So if someone's agreeing that they won't hurt themselves, you still have to do the full risk assessment. I don't think there's anything unethical about doing contracts for safety. I think it can be a useful tool, but I think it's important just to never be complacent about that, saying, okay, well, they contracted for safety, so I'm probably okay. You still have to look at the whole situation and view it as a full risk assessment.
Thank you. We have a question from Jessica Wiley. who asks, you mentioned the mental status exam. Can you talk a bit more about conducting a mental status exam over video conference?
Great question. So, one issue is if you have a framing like I have right here, you're only seeing the person's face. You're not seeing their hands, you're not seeing tremors, you're not seeing how they walk. So if you get to control how it's set up, I would recommend pulling back the camera so that you get more of a body shot of the patient. You're seeing maybe from the knees up, because sometimes you see these, nervous leg shakes, you see tics, abnormal movements, and you're often not going to get that if the person is not panned back. For telehealth to home, I think that can be one of the limitations, that the patient is controlling the angle of the camera and the distance of the camera, so you're probably not going to be able to get quite as good of a look. But most of the mental status exam, if you have a video feed, can be done by video. And if possible, if you're doing, for instance, to a remote primary care site, watching the person walk in, that's helpful to get their gait, to get more about the movements. But basically, if you're doing it by video, you can get most of those elements, including having them, for instance, do cognitive testing using paper and pencil on their end. If you're doing it by the phone, some things you just have to omit, which is why I would not recommend phone interactions as a first line. They're more of a backup option, but obviously still important if you need it as a backup.
Outstanding, thank you. And our last question is from Yasmin True Luveris, who states and asks, do you have any thoughts on the Talkspace platform and texting therapy?
So I actually don't. I haven't really looked into that. I think some of these platforms are probably going to grow in importance over the next, months to years. And I think that's probably a good thing. There are some really innovative models out there. But if you recommend it to your patient, you want to understand everything that's happening and what everything they're agreeing to is. So I think that's one of the important takeaway points, that if you are making these recommendations, if you're recommending it as a part of treatment, then ultimately if something goes wrong, the liability could come back to you. So you want to be very careful about that. And I also want to mention, before we wrap up, just a plug for two further readings. One is the Yellow Leaves 2019 textbook on telehealth. It's in the references section, great textbook, and it's available by audiobook. So it takes about 10 hours. If you want a really comprehensive read, it's a good place to start. And Eliana, maybe you could mention where people can find the resource sheet that you had sent along to me before this presentation, because that's awesome. It's, I think, about 15 pages, but covers a lot. And I would definitely recommend everyone check that out if you're, especially if you're doing telehealth and you're new to it.
Thank you, Dr. Armontrout. Yes, we have a resource guide for clinical considerations with telehealth that was produced by the Pacific Southwest MHTTC, and it is available on our website, and I will put the link into the chat box in just a moment. And with that, I'd really like to thank you, Dr. Armontrout, for a terrific presentation today. This really was phenomenal. Again, the breadth and the depth that you went into was outstanding. I especially appreciated the photos that you shared about the different camera angles. It was truly excellent. I also want to thank the participants who are here today on this webinar, and for those who submitted questions. We really do appreciate your engagement. As we come to a close, we want to leave you with some upcoming learning opportunities and what to expect as follow-up from this session. So our upcoming engagement opportunities and distance learning, as you can see here, we have suicide prevention and COVID-19 safety planning and other resources during a pandemic on July 31st. And on August 4th, we have starting a new school year, sustaining recovery from a school crisis during periods of transition. If you have missed any of our webinars, you can always access them online at our website. We have recordings, as we mentioned in the beginning. This presentation will also be posted online as well. And a certificate of completion will automatically be emailed to all online participants. If you join through the phone only, please do email Joanne Oshel at joshel@cars-rp.org to report your participation. Please allow 7 to 10 business days for certificates to be issued. And if you would like to request CE hours for this presentation, they are available at the cost of $25, and you may access them by emailing Carrie DeSell, our program manager, at pacificsouthwest@mhttcnetwork.org. We would request that you allow 1 to 2 weeks for this continuing education certificates to be issued. And again, really want to thank you for attending, and we would really like to hear from you. Our funder, the Substance Abuse Mental Health Services Administration, SAMHSA, has us administer a follow-up survey of attendees of our webinars, and these really help us to improve and continue to provide you with stellar presentations like today's presentation. And it's also important for us to report on to our funders so that we can continue to receive funding in the future as well. Please do contact us should you have questions that are related to any of the materials presented today. We love to take questions regarding training and technical assistance, and our contact information is here. And please connect with us on social media as well. So without further ado, thank you very much, Dr. Armontrout. And again, to everyone who participated in the call today, and thank you to Joanne Oshel and Matt Ike as well, who provided technical support in the background. Thank you all, and have a terrific day.
Thanks, everyone.